Getting a handle on headaches tonight on Call with the Prairie Doc. Funding for On Call with the Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Aberdeen Asthma and Allergy, Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, Dakota Care, Dakota Dermatology, the Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, and Swiftel Communications. Closed captioning for On Call with the Prairie Doc is provided by the generous support of Avera, Brookings Health System, and Fishback Financial Corporation. Headache disorders are among the most common disorders of the nervous system, yet they are underestimated, under-recognized, and under-treated throughout the world. Headaches, what helps, what hinders? We're on call with the Prairie Doc.
Good evening and welcome to On Call with the Prairie Doc. Tonight we take on the troublesome topic of headaches. Our goal for the show is to share with you the causes of headaches, some of many symptoms that accompany them, the best treatments, and what you can do to lessen or prevent headaches. To help answer these questions tonight, we are joined by headache expert Dr. Carol Miles from Neurology Associates in Sioux Falls. Carol, welcome. Thank you for joining us.
Yeah, thanks for having me.
So tell us a little bit about where you're from originally, where you did your training, a little bit about yourself.
Well, I'm from Viborg, South Dakota.
You're a Viborg person,
yes,
the big city of
I'm a
Viborg.
Viking, exactly.
Oh, yes.
Big class of 18.
Yes?
So
1918? You look a little...
Yeah.
So, just kidding. Funny.
So I graduated from Viborg High School, and then I went to University of South Dakota for undergraduate and medical school. And then I went to Vermont for my neurology training, and then I came back here in 1995, and I've been with Neurology Associates since that time.
And for your, you've kind of specialized in headaches because it's a big part of neurology, but also have you done extra training in that regard?
I didn't do extra training, but when I came here, I was the only female neurologist in South Dakota, and I think there might have been one in Sioux City too, but nobody right close in Sioux Falls. And so I think a lot of them kind of just naturally came to me because there's more females than males with headache. And so my practice just kind of gradually morphed over into more and more headache. And then I started to like it more and learn more about it. And it just kind of became what it is.
And then Neurology Associates has added a new clinic. Tell us about that.
So in July of 2013, we opened the Headache Center. And it's actually a branch really of Neurology Associates. And it's a separate clinic, and we try to make it comfortable for the headache patient. So it was fully designed for the headache patient. It was just an empty shell when we went there. So there's no fluorescent lighting. We kind of keep the lighting low, no perfumes by the staff, no scented lotions, no white walls, no chrome shiny objects. So just a more comfortable, subdued environment.
Which are all triggers for some people for headaches.
Exactly.
So, and that's been a good thing. I mean, are you pretty busy there?
It's been really busy, and we were busy with headache patients when I was at Neurology Associates only as well. But we were sort of outgrowing that space and decided that was kind of a nice population to separate into a different, because the environment is so important.
What other neurologists are there with you?
So at Neurology Associates, there's myself and Dr. Lisa Viola, and her and I do a lot of headache. Her and I are the two that are at the Headache Center. And then we have Dr. Rossing, Dr. Opheim, Dr. Garnis. We have a new one, Dr. Jeff Boyle. I don't remember if I mentioned Dr. Opheim is there, and Dr. Zimprick.
And tell us about the new neurologist, Dr. Boyle.
So Dr. Boyle came from Iowa. He's actually from Sioux City, and did his training in his medical school, I think was at Creighton. And then he came to us just in the last few months, and his specialty is neurology with sleep medicine. It's a good combination.
Oh, that's interesting. So, before we get into headaches, because there's a lot to say about headaches, tell us a little bit more about what neurologists in general do.
So neurologists in general do anything that has to do with the central or peripheral nervous system. So the central nervous system is the brain and the spinal cord, and the peripheral nervous system is the nerves after they've come out of the brain or spinal cord. So that would even include like a peripheral neuropathy or a carpal tunnel syndrome or a pinched nerve, from a herniated disc. In the brain, it's Parkinson's disease, multiple sclerosis, headaches, of course, stroke, Alzheimer's, any sort of dementia. There's actually quite a variety of things that we do, right?
Yeah.
ALS.
ALS.
We do.
Yeah. Well, we'd love to have you give us your calls. We'll answer any question you call about neurology tonight or headaches, and if you have them early, we'll be able to get to them. Call 1-888-376-6225. Ask at oncalltv.org. So give us your calls. We'd really appreciate them. And this is, people who have headaches or have a relative with headaches, the treatments are a lot different than what people think they are. There's been a lot of changes with how you treat headaches. What are the biggest major changes that you think that have occurred?
Well, I think, the treatment of headache has changed over just in the time that I've been in practice since 1995, because we understand headache a lot better. So we understand what's causing the headache, and so once you understand what's causing the headache, you can direct the treatments toward that cause. So that it makes us much better able to pick the medications that should be used. I'm researching something called iGrains that is really the treatment that we use for that is really kind of getting to the root cause. And
what is the cause of an iGrain?
So the iGrain type headache is a dull headache that kind of encompasses your entire head, but especially at the back of your head and kind of comes up to the front. It's really kind of a nondescript, dull ache that you have every day, and a lot of tension in your neck and down into your shoulders. People get dry eyes with it, and they're sensitive to lights, so they don't really like bright lights at any time. Not just with a migraine, you're bothered by lights at the time of a migraine,
right.
But they're kind of just generally light sensitive, and they really don't like headlights at night. That brightness on the dark background.
And they're similar to migraines?
They're different than migraine because they're more of a dull daily headache, and whereas a migraine in general tends to be more just episodic. Sometimes people will get chronic migraine, and they can become every day, but that's less typical.
Right. So now, and the treatment for iGrains are entirely different.
Right. So an iGrain actually has to do with the interaction of your eyes with your brain. So since you have two eyes, each eye takes a picture, and that picture has to come together as one image in your brain. And if it doesn't come together fully as one image, if it's off a little bit, your brain has to correct it and get your eyes kind of right in that correct position. We think that feeds into the trigeminal nerve, which is the underlying mechanism for headache, overstimulates that and causes this headache. So we have a test that we do. It's called a sight sync test that measures that difference.
That's syncing.
It's the sync between your eyes and your brain. And the way that we treat it is with a special patented lens called neural lenses.
So you're doing that right now at that headache center?
Right. We are. We did a study of 186 patients that we completed a couple of years ago, or a year and a half ago. And so now we're moving forward with that, and actually we're setting up a more rigorous scientific study right now.
So let's talk about causes of headaches in general, and I want to start with migraines, because it used to be thought that migraines were really the spasms of the arteries,
right.
The subsequent loss of blood flow to certain parts of the brain, the subsequent dilation of the arteries and the veins, and then it was all vascular.
And actually, that's what I was taught in medical school.
Right.
That's an old theory by Dr. Wolf. And actually, I had medical students with me today, and I asked them what they were taught, and they're taught the same thing. But it's really evolved over just the last few years.
Right.
And we know that it's not really probably
vascular.
very much vascular. There's a little bit of vascular component, but it's probably more an effect of the migraine than really a cause. So it's changes in the chemicals in your brain. It's overstimulation of the nerve to your face, the trigeminal nerve. When that gets overstimulated, it overstimulates in the brainstem, and then that goes to involve your entire brain. And so it causes the pain and the nausea and the light sensitive and the irritability and the confusion, and it kind of encompasses really your whole brain.
So it's neuro and chemical, it's not vascular.
Right.
So I mean, we're
Exactly.
going to talk more. 1-888-376-6225. We need your phone calls. We need your questions. Your show is those questions that makes this show. So there are other causes of headaches, though. But you're talking a lot of trigeminal. There's this nerve. What is the trigeminal nerve?
the
We've
trigeminal nerve-
got a drawing here. Show us what
The trigeminal nerve it's the 5th cranial nerve, and there's really 3 divisions that you can actually see here. So there's the one division called the ophthalmic that's way up at the top here, and that's really the one that's responsible for migraines, because that one is it's the area where migraines are right through here. It also innervates the sinuses, which is why people that have migraines get a lot of nasal stuffiness and pain in the sinus area. It also innervates the meninges, the linings of your brain,
Right.
and that hurts. That's why meningitis hurts.
Right.
So that's the first division. There's a second division, and then there's a third division, but they're not as responsible for the migraine component. They can hurt, and they can cause other things like trigeminal neuralgia, but not the migraine component.
So you snuck in on the issue of sinus pain. A lot of people will go to their ears, nose, and throat. They'll go to their regular doctor. They'll say, I'm having a severe sinus headache. It's all from the cold, and then I got a bacterial infection, and give me a Z-Pack.
Right.
Tell me, how wrong is that?
So actually, they did a study, and 70% of people that think they have sinus headaches is actually migraine. It's that common. And I get referrals all the time from the sinus specialist and from the ear, nose, and throat that they look at the sinuses and they're clear, and then they send them to me, and it's really more of a migraine component. And it's because it innervates the sinuses, so that pain is in that same area. It also causes some nasal stuffiness and clear nasal drainage, not colored, and there's no fever, which would be more indicative of sinus infection, but it feels like a sinus infection. Migraines are worse seasonally in the spring and fall, and migraines can improve a little bit with like Sudafed. And so all of those things make people think it's probably a sinus infection or sinus-related headache.
And they want the antibiotic because that's what they had last time, and it went away.
And it's not going to work.
And it doesn't work.
Right.
So what is the best thing that a person could do over the counter or without going to the doctor for that kind of pain?
So the best thing is to try to treat it with over-the-counter medications that are kind of simple to get and really pretty effective. If somebody thinks it's a migraine headache, I prefer that they use like Aleve, naproxen, that category, even ibuprofen. Some people will reach for Tylenol or Excedrin, but those have a really big risk for rebound or medication overuse headaches. Those are synonyms.
And so, we need to talk about medication overuse headaches.
So those aren't probably the best ones to reach for.
But so ibuprofen or naproxen?
Yeah, yes,
Wow.
those are good ones to reach for, right?
All right. Cold, hot, any heat, decongestants?
I always tell people that whichever feels better. Some people warm packs feel better. Some people cool packs feel better. And so whichever one feels better, they can also be helpful.
I have a ocular migraine. Want some information about eye grains, and we'll talk about those later. Why are some people sensitive to perfumes? Here's a perfume question.
So there's a lot of triggers for headaches and particularly migraines, and a lot of them are in the environment and you can't avoid them. So perfumes or potpourri, things, scented candles, things that you don't realize are there until you're already in that environment. And they're just triggers. So they trigger the headache and start you into this headache cycle, and then you can't stop it. So weather change can do it. There's just so many things that can trigger.
Okay. All right, and then the final thing, headache sufferers can't avoid the general public who wear perfume. Do you have any suggestions on preventing perfume-induced headaches? One is to encourage people not to wear so much perfume.
Right, and yeah, if we could do that, that would be probably good. But
there's a lot of people out there that suffer, and the other people are thinking they're doing a good thing because they don't want to smell bad. They want to smell good.
And that's actually why specifically we avoid perfumes and scented lotions in our office on the staff. You can't avoid people that come in that have that. But sometimes if people are really, really sensitive and they just can't avoid it, and they're going to get 3 headaches a week because they're exposed to these different things,
then nurse medicine.
Then you need a preventive medication.
Okay.
Yeah.
All right. People may experience headaches after looking into the sunlight for too long, hearing loud noises, having poor posture, or changing their medications. Let's take a look inside the body to better understand what physically causes these head pains. Headaches can result from many causes in the body. The most common type of headache is from muscle tightness, spasm, irritation in the shoulders, the neck, the jaw, scalp. Commonly these are called tension headaches, sometimes related to osteoarthritis in the neck, over or under exercising, stress, depression, or nothing. We don't completely understand why migraine headaches occur either, but we think that these miserable experiences are due to an activation of one of two systems or both. Some experts think the nerve brain tissue bursts with activity and then slows down, and this dominates the headache process. But other experts think the blood vessels are primarily responsible, with constriction of the arteries and then dilation in the central brain stem, or with such vessels that feed the nerve tissue of the outside of the brain and the scalp and around the eyes and muscles of the head and neck. There are headaches that are generated from pressures that's too high in sinuses, more often from blowing too hard than from infection. Or headaches can be from an irritated fifth trigeminal cranial nerve called trigeminal neuralgia. Just looking at that makes my head hurt. Or it could be from such causes as temporal arteritis. The artery of the temple can go into an inflammatory process, and that can cause the headaches. Well, headaches can be caused by such conditions also, like infection or tumors or bleeding or clotting. But these causes are fortunately quite rare and are pretty clear in the way they present themselves. Increasingly, we are seeing headaches from medication, often called rebound pain medicine overuse syndrome. As you can see, the headache is more than one thing, and it's such a complex and complicated story that treatment must reflect careful and thorough examination. Go into your doctor or PA or nurse practitioner and get seen. So make sure that you give us your calls and your questions at 1-888-376-6225. Let's talk about rebound pain medicines. I mean, it's shocking to me to think that the Tylenol might be one of the reasons why people have headaches. Explain that.
Well, people that are prone to headaches are a little bit more likely to get what used to be called withdrawal headaches originally. Caffeine withdrawal would be kind of the most known type. And then they changed it to rebound. And then they actually changed the name to medication overuse so people know what they're doing. They know that what they're doing is actually causing the headache.
Medication overuse.
Right. And so medication overuse headaches happen if people are using any sort of pain medication, whether it's Tylenol or morphine. If they're using it more than 3 days per week, that's kind of a general rule. Some people can get it with a little bit less, some people with a little bit more. But if you're using pain medications 3 days per week for several weeks in a row, then you start to notice the medications lose their efficacy. They become less effective. You take more. And they just don't work, but people kind of keep using them sort of as a security blanket. Oh, I don't want that headache to come back. And they just get into this cycle.
So it's amazing. I mean, the very medicines that we're using for a headache can be the reason for the headache.
Right, and what the medication overuse headache is more of a dull, sort of diffuse headache. People always, if you ask them to describe it, they say it's just there. Because it's not really something that you can even describe, but they always have some degree of head pain. So it's dull, but it's a nuisance and it's annoying because it's there all the time. People wake up with it, and then it follows the life of the drug. So if you take your Excedrin or Tylenol, 4 hours later, the headache comes back. You redose, 4 hours later, the headache comes back. You don't take the offending agent through the night, so you wake up with a headache, and you start the cycle over again.
Yeah. So and it used to be that a lot of people had medicines with caffeine in it.
Right.
Is that even worse for a rebound?
Well, caffeine is a big rebounder, as is Tylenol. So some of those medications have both of them in it. So Excedrin, Furoset, They both have caffeine and Tylenol in them.
I mean, but those are effective agents for migraine.
Right. So they're effective agents if you use them infrequently. So for the person that gets one headache a month that's not very severe, Excedrin is great. It's cheap, it's fairly safe, it's a really good medication to use. Those aren't the patients that end up in my office, so I don't think I've ever told anybody to take Excedrin, but they're good medications.
So used, now we have a rolled in on an old Anacin commercial I wanted to show.
Good. Hi, darling. Hurry and get ready for dinner. PTA meeting tonight.
Ellen, please, I just got home. Don't rush me! Control yourself. Sure you have a headache. You're tense, irritable. Don't take it out on her.
You need Anacin for fast relief. The big difference in Anacin makes a big difference in the way you feel. Minutes after taking Anacin, headache pain's gone. So tension's gone, irritability's gone. You're in control again. You see, Anacin is a combination of ingredients that contains the pain reliever prescribed most by doctors. So for headache pain, remember, an aspirin tablet gives some relief, and with buffering you get some. But an Anacin gives this same pain relief, plus extra relief power, plus the power of an extra ingredient. So millions get fast relief without stomach upset. The big difference in Anacin makes a big difference in the way you feel.
I think it used to have another ingredient like Tylenol in it. So it was aspirin, a Tylenol-like ingredient, and caffeine.
Just like Excedrin now.
Right, and then it dropped one of them because...
they probably dropped the Tylenol.
The Tylenol-like active drug. I hope we're not being negative about Anacin, but it's probably a very effective drug for an occasional headache.
Right.
But not 3 times a week.
Or more.
Or more.
Exactly.
Yeah, and that's the take-home message. Anything else that we want to say about medicines? Because we're going to dive into questions. We got some good questions.
I just have one other thing to say about medication overuse headaches, because this is really important.
Okay.
If you keep taking those medications 3 days per week or more, anything that your doctor gives you for prevention is not going to work. It's going to sabotage those efforts. So once you start a prevention medication, then you have to come down off the whatever you're overusing, or it just won't work. So you have to just kind of wean your way down.
How fast do you drop them?
It's different for different people. So I usually tell people to do it over a couple of months, but if they're using a lot of it, it might take longer. If they're only using one...
So you taper very slowly.
Or they'll withdraw.
Or they'll have withdrawal.
And they'll get a bad headache, right.
Yeah. One other question before we hit the questions. You're a runner. So how important is physical activity and prevention of chronic pain, for example, or headache pain?
Right. Exercise is really important for headache prevention. It's one of those things that you can do that is not a medication. And it's different for different people how much they need to run. But we think it's probably about 20 minutes, 3 to 4 times per week. So it's not like a huge amount, and you don't have to run. You could go for a 20-minute walk. You could go do aerobics. You could go to the pool. You can go on the bike. Just get out there with the stroller. Just get your heart beating for 20 minutes at least 3 times per week, and that helps.
I say every day. And 20 minutes every day, it is worth it. But why does it work?
It probably increases the natural painkillers, the endorphins, and helps. It also causes some muscle relaxation, just from the relaxation effect of it. We don't really know exactly how it works, but it is proven effective.
Very good.
Right.
She said it. Exercise is very important. Well, we have a question. How might diet affect one's susceptibility to headaches and migraines?
So diet is also, your diet is full of different triggers as well. And I have lists of foods that can cause the headache, but everybody doesn't have the same thing. So I tell people the big ones. So too much caffeine is a trigger. NutraSweet or aspartame, anything in diet sodas, is really bad. I think that actually, over time, as I've done this for such a long time, I think that NutraSweet is maybe a bigger culprit than even caffeine. However, I haven't read that. That's just my own experience. And foods with preservatives.
Right. I mean, sardines or dried meat or...
Well, I think a big one is lunch meat. If you're getting prepackaged lunch meat, it's full of preservatives. If you get lunch meat, it lasts like 3 weeks. But if you get it at the deli, it lasts 4 days.
Yeah.
Because it's just full of preservatives. So those are the big ones.
Nitrates? Is it the nitrates or nitrates?
I think it probably is. And so bringing that into things like hot dogs, salami, bacon, aged meats.
Orange juice?
Orange juice can. And some people, I always tell people you can have a juice glass, not a big glass of orange juice. So too much citrus actually can. I read one time more than 10 grapes. So there's certain things, but I don't like to tell people all of those things because it might not be a trigger for them.
For them, and
it's better to try to identify your own triggers. Alcohol is also a huge trigger that I didn't mention.
But I've heard that particularly red wine or beer have those things, but that vodka doesn't, and that's the one that you can drink.
Right, vodka's the only one on the list that's okay.
But you don't want to mix it with orange juice.
You can't mix it with orange juice. Right.
So vodka tonic. We're not promoting vodka tonic. A martini with a vodka martini. We're not promoting that. I'm just saying those are options.
It's on the list.
Madison, South Dakota used to get severe migraines, gone now, 72 years of age, but sometimes loses part of her vision. Why is this?
Okay, so as people get older...
Man, it's a man.
Okay, as people get older, they naturally, their serotonin receptors decline with normal aging. And so headaches you can grow out of them. But I think it's really in like about the 65-year age group where I start to notice that. But you're still susceptible. You're still a migraineur. You're still a migraine person. Right, and so you're still susceptible to it. And so sometimes people will get a duller headache, or they'll get the aura that they had before, which may be the visual change, or maybe some numbness or tingling, or maybe some irritability, or kind of the things that went along with your headache and not get the full spectrum.
So some migraine people will have a headache and they'll have a neurologic loss with it. I always worry that they're going to, that could be permanent. Why would it be occurring? Makes me think vascular, see?
Right, and that's actually a lot how the vascular theory came to be. So people can get people would call them complex migraines or complicated migraines. It's really a migraine with aura. So it's any neurologic symptom. So it might be scintillating scotoma, those shimmering lights. It might be flashing lights. It may be brilliant colored geometric objects, a kaleidoscope. It might be a black spot. It might be numbness. It might be weakness. The ones with weakness worry me the most. They deserve a full, complete stroke workup.
Yeah, make sure there's no vascular things going on.
You can even have loss of speech. There was somebody on TV, a broadcaster, who lost her speech during one of the broadcasts a couple of years ago, and that was on TV a lot. Yeah.
I get that, but it's probably because I'm tongue-tied and I'm an idiot. But other than, you know. But that's
scary to watch that happen. Yeah.
Okay, let's just roll through the questions. An 84-year-old Wakanda person, female, has how is vertigo related to headaches?
So vertigo is actually one of those auras as well. So vertigo means a spinning type sensation.
Right.
So it's dizziness, and that can come from lots of different things, but it can be associated with migraines, and it's called migrainous vertigo, or vertiginous migraines. They just put the word together, and it's part of the aura. And their aura, instead of coming so much from the trigeminal nerve, it comes from the brain stem itself.
Okay.
And that's where you get the vertigo from.
Okay. All right, now let's just explain an aura with migraine. What is an aura?
So an aura is just part of the migraine syndrome. Only about 20% of people get that. However, people always think with a migraine, well, it's not a migraine. Sometimes people will tell me because I don't get the visual stuff. It's actually only about 20% of the migraine patients that get that. So it's any sort of neurologic symptom that comes with it, usually visual, tends to last about 20 minutes. We want it to last less than 2 hours. If it lasts longer than 2 hours, then you should definitely let your doctor know. Now, if it comes and goes during that 2 hours, that's fine. It starts over each time it starts again. But you don't want anything to last straight through for 2 hours, or just let your doctor know because you might need a workup.
Or anything else about migraines that we should make sure people know?
If you do have an aura, it's good to treat with the aura. You can treat it really early. So let's say you can use Aleve, and it works fairly well for you. If you can treat it with the aura, and the aura lasts for 20 minutes, that medicine is going to start working by the time the headache starts, and so you can really shorten up that headache.
Shorten that headache. Mm-hmm. Wow. How many people need to have a preventive medicine for migraine?
Well, as a general rule, if somebody has 2 or more headaches per week, they could probably benefit from a preventive medication.
It's not like acutely treating it with the pain medicine. It is like treating it with a preventive.
Right. So preventive medications. Preventive medications you take every day, whether you have the headache or not, to make the headaches less frequent, less severe, and shorter. And it takes a few weeks for that to happen. The symptomatic medications are the ones that you take when you get the headache. So a lot of people will be on a preventive and add a symptomatic medication when they need it.
Okay, all right. Selby, South Dakota, spinal stenosis. Ask if it's related. What can be done with the recent diagnosis of spinal stenosis?
Well, spinal stenosis, it sort of depends on where that is. That's narrowing within the spinal canal. So if it's in your neck, it can certainly trigger more of the tension type headaches, not so much of the migraines unless it's really high. However, it can cause occipital neuralgia if it's really high, and that feels like a migraine. The occipital nerve innervates the top of the head. But any of those things that cause pain can trigger into migraines as well. So it all could potentially be related. But somebody with cervical spinal stenosis, it's probably more from the stenosis and arthritic change and then muscle spasm, and less likely a migraine type syndrome.
All right. If you've ever had chickenpox, you've had a chance of developing shingles. One of the possible effects of shingles is to cause severe head pain.
I got shingles a year ago last November. It's been almost a year and 3/4 ago. It started on this side of my head. And you can get shingles all over your body, but on the head is the worst place to have it. And it worked its way it's kind of like chicken pox. You get sores. It was in my ear, it went down. It was actually in my mouth. And this half of my face went numb because shingles can only be on one half of your body. It can't be on both sides. But literally, it split my head in half. This side was numb, this side was normal. And just the pain of having shingles is pretty bad. Went to the doctor, went through they give you herpes medicine, they give you gabapentin. Went through the regimen on that, and it cleared up and everything was fine. I went off the meds, and within 5 days, I'm getting up in the morning about 5 in the morning, and it almost feels like an electrical shock in the side of my face, and it went up to here and literally blacked me out. It was white hot pain, the most pain I've ever had in my life. I've broken bones, I've been in accidents, I do a lot of labor. It took me, it happened when I was in bed just getting up to go to work. My house is very small. I made it to the bathroom and all I could do was stand there and scream. The most intense pain I've ever had. It doesn't last very long, a couple minutes maybe. It seems like forever. Went back to bed. Within a half an hour, went right back up my head again, hit me again. Same thing, it's the best thing I can say is just white hot, intense pain. It would be like a blowtorch being on the side of your face. I found that if I took a damp cloth, didn't have to be cold, didn't have to be hot, put that on the side of my head and looked up, it went away faster. Don't know why, but that worked. Saw a neurologist, and her suggestion was to take more gabapentin. Shingles is very painful. I was talking earlier with Rick's wife, Joni. If I'm in a crowd of people, I don't care what crowd it is or where it is, if you bring up shingles, 30 to 50% of the people that you talk to have had it. About the shot, I've talked a lot of people into getting it. I think they ought to give it to people earlier than they do. And I think they could give it to them earlier because I've talked to people of all ages. Now, I don't think you need to get it in your 20s or 30s, but I think mid-50s or so, I don't think it's a bad idea.
Thank you for that, Dave. It's a very interesting story. I will point this out, that the CDC says 60 and older. Most insurances will cover some of it. It's about a $250 shot. If the people who sell the shot are saying 50 to 60, Dave says it's worth it. We know that it isn't one of those perfectly effective, but that it's 50% effective or 60% coverage. So it reduces the effect by 50 or 60%, and it reduces the post-herpetic neuralgia severity by 50%. So it's worth doing. So Dave mentioned that the shingles only affects one side of the body. Could you explain that?
So the shingles is from the same virus as the chicken pox.
Right.
And so when you've had the chicken pox, it lies dormant in the nerve root. It stays there after
Right.
you've had it. And then if you have, I think most commonly stress, then it can come back out through the nerve root, and it can actually go into any of the divisions of the trigeminal. So the first, second, or third division, and people will describe the pain just traveling right along there. And they describe it just like Dave did. It's a searing, shooting, very, very severe, take you to your knees type pain. And I always tell people, the nerve's job is to feel. That's their job, is sensation. Right. And so when it does that abnormally, it causes shooting, burning, itching, different types of pains because it's abnormal.
Right, and of course the trigeminal nerve does just exactly that. It goes to all those three. The question I would have is trigeminal neuralgia has been described by me. It sounded just like Dave Schinkel's pain. So it makes me think that many of those people with trigeminal neuralgia may have something like chickenpox, and maybe we didn't have the rash. What do you think of that?
It may be that the rash was missed, but some people can just get it without any particular cause. It's also where that nerve is deep to the ear, there's an artery right by it, and that can just pound on it and cause that searing pain. So sometimes if you can't get rid of it with medications like gabapentin that he was talking about, or maybe carbamazepine, different anti-seizure medications, exactly, then the neurosurgeon can go in and put a little sponge between that nerve and the artery to prevent that damaging that nerve and causing that searing pain.
What about post-herpetic neuralgia? I mean, people will have for example, that'll follow this neuroderm. Let's say that it's this nerve, it'll wrap around and then the front side another. Or it could go down the arm, or it could do the neck, or it could do the trigeminal nerve. What about treatment for post-herpetic neuralgia? I mean, cutting the nerve, or steroids, or treating it with gabapentin, or what?
Right, and those are all choices. So gabapentin we like to use because it's pretty easy to use. It doesn't interact with other medications. You don't really have to follow labs with it. Carbamazepine, or Carbitrol, or Tegretol, there's different names for that. That's really effective. It's a little harder to tolerate. It can interact with other medications. You've got to follow some labs. It can give people double vision or make them really wobbly with walking if that dose gets too high. Yeah. But it's really effective, and people will take that over nerve pain.
Now there's a gabapentin-like drug called pregabalin, also Lyrica.
Right.
People are going to think about that.
Right.
Well, it's much more expensive. Is it any more effective?
It's a cleaner drug. So it's like they took gabapentin and made it a little cleaner with fewer metabolites, and so therefore fewer side effects. I like to start with the gabapentin because it is cheaper, and it sort of really depends on their insurance company too, what the cost differential is. But I like both of them. They're both effective. And so oftentimes I'll start with gabapentin, see how high I can get on the dose. If the pain's gone and they're side effect free, then I'm going to leave them there. But if they're getting side effects and I would like to go higher, then I might switch them over to Lyrica.
I think the idea of starting with the less expensive, you can say it's not that expensive for the patient because the insurance company's covering it. The problem is we're the insurance company.
Increases your premium ultimately.
It increases everybody's premium.
Right.
And so we have to consider the insurance company's cost or the government's cost, Medicare's cost.
Exactly.
When we're doing any drug.
Right.
So here's from Sioux Falls. Oh, I wanted to ask about cluster headaches. How are they different than trigeminal neuralgia?
So cluster headaches are probably a little bit more similar even to, really kind of a trigeminal neuralgia, or even similar to migraine because it involves that same nerve. Cluster headaches are more common in men, and they can start in the 50s as opposed to in the teens or 20s or 30s that a migraine would. And it's a really strong searing pain as well. The patients that have that, though, they also get a watery eye and a runny nose, sometimes a red eye or a little bit of a droopy eyelid. And instead of laying still in a dark, quiet room, they pace around, bang their head on the wall, and it lasts about 15 or 30 minutes, which if you've ever seen somebody in a cluster headache, it's very anxiety provoking. They're very anxious, they're in severe pain. It's hard to watch it because they're so uncomfortable. So a migraine can last, usually would be 6 to 8 hours. This is 15 to 30 minutes, but a severe pain.
So people come to emergency rooms with migraine headaches, with cluster headaches, with trigeminal neuralgia, and oftentimes their treatment is narcotics. How effective is narcotics for this kind
You know,
of
I
thing?
think we've gradually, in the emergency room, I think they've been doing a really good job at getting away from using the narcotics, at least where I'm working, I see that. There's medications that are much better to get to the root of the problem and help prevent it from occurring, to stop that pain, as opposed to a narcotic that's really covering up the pain. And the problem is you build up tolerance to narcotics. So kind of like the rebound, you keep using more and more and it becomes less and less effective.
So what are those better drugs for a migraine in the emergency room?
Well, in the emergency room, you know, Toradol shot is a really good choice, which is ketorolac. Imitrex injection, the subcutaneous injection, is a good choice. Just getting a liter of IV fluid might be effective. Reglan, which is a nausea medicine, metoclopramide, very, very effective. Actually, there was a study that showed 20 milligrams of IV metoclopramide was more effective than Imitrex shot, and with fewer side effects. So that's a really good choice.
Reglan.
Reglan, which is made for nausea.
Right.
But it helps for headaches, and I use it for headaches all the time.
Metoclopramide.
Metoclopramide. I also would use steroids in the emergency department in an IV. I use Depacon, which is a seizure medication that I would use.
Depacon, which is, I've not heard of
Depacon
it.
is it's an IV Depakote or valproic acid, and it's very, very effective. So. I have a set order sheet in the ER at Avera that they can just kind of pick and choose what I like to use.
Shooting pain in the head, a symptom of anything? I mean, people will get the shooting pain. Is that a migraine?
It can be a migraine, particularly if it's lasting longer. Now, some people will get what used to be called ice pick headaches, and I really like that name. Now they've changed that to something called primary stabbing headaches. And those are those really sharp, severe headaches that last like about 3 seconds. And then you can get several in a day, and then they'll go away for months, and then you'll have it again. And it's a really bad pain. It's a variant of migraine. And so it's a little bit more common in migraines. But it's a bad pain. It's hard to treat it because it's gone in 3 seconds.
The guy with the cluster headache, eyes watering, and he's hanging, running around the room, banging his head against the wall. Everybody in the emergency room would likely give a great big dose of narcotic, but you're saying no. These other things, the Toradol is a better choice.
Well, for him, I would probably use oxygen. Oxygen works, but particularly if you're in the ER, you've got the oxygen, so they can put oxygen 100% by face mask for 5 minutes and get rid of it. You could also use the Imitrex shot, which is pretty quick. Now, the cluster headache patient is a little bit different than somebody with maybe a lesser degree of pain. And for those, again, if you watch it, it's very anxiety provoking. So giving them a couple milligrams of morphine to kind of settle them down while I can get the workup done is sometimes not unreasonable. You know, you always want to treat the pain, but you want to just not reach for the narcotics if you can help it.
So I've had a nephrologist, kidney specialist on the show saying over drinking of fluids and hydration is a bunch of hooey. We don't need to push all this water. What do you say as a neurologist, a headache specialist? Is hydration or dehydration ever a cause?
Dehydration can be. And actually, the reason we use IV fluids is if you give them a more rapid bolus of the fluids, we know just from experience that works. So let's say you have a younger patient or somebody that's pregnant and you just really can't use the medications. And so you want to do it as safely as you can. Or if it's a migraine person that's been vomiting all day, they're probably dehydrated. And so you need to give them the fluids, right?
What is your view on the Cephaly electric stimulation unit that stimulates the trigeminal nerve?
I like that. And it's sort of like a headband. It's a TENS unit.
Right.
It's like a headband.
Meaning it just kind of gives you electrical
a little
shock.
bit of an electric stimulation, right? And it's instead of, people use that for lots of different pains, and you just would put this patch wherever. This is one, it's got a patch that goes right on your forehead, and it's got sort of a headband, or it looks like you would put your sunglasses up above on your forehead, and you do that for 20 minutes every day as a preventive medication. And the studies look good. I have a few patients that are using it, that like it. People that like that are people that don't want to take a medication, which is actually a lot of people. People with chronic pain, 80% of them would like to go down on their medications and use a device.
So chronic pain, some people have fibromyalgia, they have chronic belly pain, pelvic pain, chronic pain. A lot of that's very much like headache. But the pain medicines are not always a very good treatment, and of course narcotics in particular.
Well, narcotics have so many side effects. You know, they can cause constipation and belly pain and blurred vision and confusion, and in elderly people, if they're confused
Falling,
and they fall, right?
fractured hips.
And so they just, and then of course there's the addiction. So my preference is always to avoid narcotics. We very, very rarely would give anybody a narcotic through the headache center. That's going to be our very last choice.
Wow, that's amazing. Warner, South Dakota, is this ocular migraines the same as eye grains?
No, they're a little bit, they're different. So an ocular migraine is what we would call a migraine with visual aura. That name has kind of changed over time. The naming of the migraines has changed over time. So an ocular migraine technically is somebody who has the visual aura. And they might not even have the headache. They can or they might not.
And they have the little word.
They can have the scintillating scotoma, which is the shimmering lights. They can have the flashing lights, the kaleidoscope, a black spot that kind of floats around. So that would be an ocular migraine. The eye grain is a little bit different, and it's more how your eyes work together, and if they're not working together and synchronized in your brain, it causes a dull daily headache, and not any sort of flashing lights or black spots or anything. So they're different.
The biggest clue to eye grain that you could know is, what would clue you in that you have eye grains?
The biggest thing is chronic daily headaches and neck pain. And that's a lot of people.
You're right.
And so the way that you narrow it down from there is if you have other symptoms as well. Like if it worsens when you're reading or working on the computer, if you get tired when you're reading or working on the computer, if you don't like headlights at night, if you like your computer screen light turned down, if you like your cell phone light turned down, those are all
clues that there might be eye grain.
Exactly.
And the treatment is not any of these pain medicines. It has to do with lenses.
Right, because the lenses have to synchronize that all together. Wow. Right. And your brain's trying to do it, but it hurts when it does that.
Sioux Falls, please address motion sickness and vertigo.
So motion sickness is really common in patients with migraines. And so a lot of times people will have motion sickness when they're younger, and then over time they kind of evolve into the full migraine syndrome as well, but remain kind of motion sick. We don't know exactly why that is. We think it has to do with the hypothalamus probably, but we don't really know for sure. And so the motion sickness can be a little bit different than vertigo.
You don't think it's the semicircular canals of the
I don't
ears?
think so, not as far as the migraine component. Certainly if you have a problem with your semicircular canals, you can get those things as well. But vertigo is a little bit different than motion sickness, because vertigo is really a true spinning sensation or a sense of motion, and that can also be part of the migraine syndrome. So you can really have motion sickness, or you can have vertigo, or you can have both. It's just part of the syndrome.
And you might be able to treat it with gabapentin
you can treat them with any of the migraine. You can treat them with any of the migraine therapies. So gabapentin is okay. I don't love that one as much. Carbamazepine, I use that for the trigeminal neuralgia, not really for the migraines.
So the best medicine for migraines, verapamil.
Well, I like verapamil. Anybody that's had my patients knows probably that I like verapamil.
It's a blood pressure pill, a calcium channel
It's a calcium channel blocker, and the studies don't hold that one up as well, but I really, over 19 years of doing this, I really see that one to be very effective. You can also use beta blockers like propranolol, atenolol, metoprolol. Those are common. You can use antidepressants like nortriptyline, amitriptyline, venlafaxine, which is Effexor, all good choices. Botox is great. We haven't talked about Botox. Botox is a great choice for chronic migraines. So you have to have 15 or more headaches per month for at least 3 months to get that, and have tried at least 2 other preventives.
And it's expensive.
And well, it's now covered by the insurance companies because it's FDA approved for chronic migraine as of 2010.
And the insurance companies have to pay how much?
You know, I'm not sure exactly. I think we pay $500 a bottle before we open it, and it comes as a precipitate, and you mix it up, and before we inject it and do any of that. It's expensive. And I'm not sure, actually. I haven't looked at that.
But if it works.
Right, if it improves somebody's quality of life and they're able to go to work and go to soccer games and get back into life, then it's worth it. Another preventive we didn't talk about just right now is the Topamax, which is one of my favorite ones as well.
Topamax, which is?
Yeah, which is topiramate, which is a seizure medicine. So I like topiramate, I like Botox, and I like verapamil as probably my favorite choices, but it's very individual.
Topamax makes you a little groggy?
It doesn't usually make people so groggy as it can cause a little word finding difficulty. Yeah. And so a little bit of cognitive slowing. Right. And so that's a problem.
I haven't been taking Topamax. I wanted to add that. Quickly, MSG for headaches?
So MSG, again, is a trigger. So MSG is really known for being in Chinese food, but it's also in like things with a lot of flavor, like flavored chips, like barbecue chips. It's in a lot of soups. It's in a lot of things. You have to look at the label.
Chinese food.
Chinese food is the most.
And it will cause headaches in some people.
Right. It's a pretty strong trigger.
Okay. All right. We'll be back right after this.
But what if Mary comes out of the coma?
I will forever be with you, even if she walked through that door right now.
How's it going? Yo.
You never know where you'll find the flu bug hanging around this time of year. Get vaccinated. It's free for children 18 and under. Because stopping the flu starts with you.
I didn't think we could do better.
Come on, never hurts to look.
So we went to Medicare.gov.
Found lower copays. We're happy.
Medicare open enrollment.
You'll never know unless you go.
There's some 200 different kinds of headaches, and about 90% are the non-dangerous type. We're not talking about how miserably or painful headaches can be, just that most are not dangerous. This is about how to recognize when a headache might be dangerous and when to come in and see the doctor or care provider. I was an intern working in a big city hospital emergency room one late afternoon, autumn day in Georgia, when a tall 40-something-year-old guy lumbered into my tiny exam room with the worst headache he'd ever had. He was a hiker who spent a lot of time out in the woods with his dog, but who was so miserable he wanted nothing to do with hiking this day. He was running 102-degree fever, and he hurt everywhere I touched, especially when I bent his head forward. He had a light pink rash, especially on the palms of his hands, and he reported plenty of exposure to ticks lately. To make a long story short, the tests take a week to come back, but we treated him for Rocky Mountain spotted fever and later proved that that was the case. What clues are there to know when to do more than just cover up a headache with some pain medicines? In general, people are safe if the headache is associated with a viral syndrome, is something similar to headaches in the past, and has been defined already as a migraine, a tension, or a neck arthritis headache, is occurring in a person otherwise healthy, or is accompanied by no other significant new physical or neurologic symptom. On the other hand, people are not so safe if the headache is completely different than any previous headache, is the worst headache ever, strikes suddenly like a thunderclap, is associated with a significant fever, generalized illness, stiff neck, or weight loss, comes with new one-sided face, arm, leg weakness, or vision change, or is a new, progressively worsening headache that is happening in someone over 40 years of age. Of course, these are just guidelines. If you have any question, seek professional help. My woods walker had an unusual and severe headache with a generalized illness, and if not treated early, might have resulted in his death. As an intern, I was glad I'd been listening during the lecture on the causes of headaches. Well, this brings us to the end of our show this evening. I sincerely thank our fantastic guest tonight, Dr. Carol Miles. As often happens on the show, time ran out and we didn't get to all of your great questions. So to hear our answers to more of those questions, please join us now, right now, on our website, oncalltv.org, where we will continue live with On Call After Hours on the web in just a few minutes. As the winter months approach, be sure to get your flu shot. It's one of the easiest ways to reduce your chances of being sick this flu season. On Call with the Prairie Doc will not be on next week, as South Dakota Public Broadcasting will be airing high school football championships. Tune in and cheer on your favorite team. We'll be back in November 20th at our regular time with a look at the Veterans Administration and their health care programs. An anonymous wag noted, if you have a lot of tension and you get a headache, do what it says on the aspirin bottle. Take 2 aspirin and keep away from children. And until next time, stay healthy out there, people.
While the U.S. veteran population is expected to fall from 23 million in 2010 to a projected 14 million in 2040, they will always be an important part of our society and deserving of our care. The Veterans Administration is charged with overseeing that care. Lessons from the VA. Next time on Call with the Prairie Doc.
Hello and welcome to On Call After Hours, where we answer the questions we weren't able to get to during the broadcast portion of our show. All of your questions are important to us, and we want to answer them as well as we can and as many as we can. So let's dive into it, Carol. Thank you so much for staying
you're
late.
welcome.
Volga takes Tylenol for back pain. Does it matter if she switches from Tylenol to ibuprofen and back again?
Some people that do not have headaches may not develop rebound type headaches, so it sort of depends on if that's part of her story. But switching from one back to another one doesn't help as far as the rebound component. It may help as far as the back pain component, but you're not less likely to get rebound headaches by switching.
But as a generalist, I'm not a fan of ibuprofen because there's so much kidney problems and blood pressure problems and stomach problems. So I kind of think that's a reasonable thing. And if you don't get headaches from the Tylenol, then great.
Right.
Vehicle accident 84, fourth nerve palsy, vision, different types of lenses alter other than prisms.
So the fourth nerve palsy is a little bit different than what I was talking about with eye grains, and it causes kind of a skewing of your vision, and they require prisms. And the optometrist and ophthalmologist work with that, but it can cause a headache because your eyes are not aligned, and it causes double vision. And then you put the prisms on, it realigns your vision, and then that can improve a headache component.
If there are headaches, you might keep on plugging away.
Right, you might just need some change in your prism, but the ophthalmologists work very closely with that. Those are hard.
They're tough.
Yeah.
Vermilion used to call silent migraines aura with then optical migraines.
So I think probably what they're talking about, they used to say if somebody had an aura and no headache, they'd call it an aura without a headache, or
a silent migraine.
I think that was even before my time that they called it a silent migraine.
It was during my time.
And so now we would just call it a migraine aura, and I would, if I was going to write that down in my notes so that I remembered, I would say a migraine aura without the associated headache. So just different terms.
Surgery for trigeminal neuralgia.
So the surgery is what I was speaking about, where they'll put the little sponge between the artery and the nerve.
Or do they ever kill the nerve?
They can do that too, but then you're going to get numb.
Right.
And actually the pain can come back too. So it's not a great fix, and it hurts to get that done. Now it sounds like a pretty little thing to put a sponge between a nerve and an artery. I mean, you and I could do that, sounds like. But it's really deep in there, so it's not a little surgery. It's a big deal.
But it works pretty well?
But it can work, right. Yeah.
And I've heard for post-herpetic neuralgia, cutting the nerve doesn't seem to take away the pain.
Yeah, it might not. It's just like phantom limb pain, you know, if you lose an extremity, it can still hurt because the nerve knows where it was supposed to go.
Yeah.
So it can still hurt, right.
Yankton, linkage, MS, headaches, and trimoralgia.
So MS can have a lot of different things with it, and it can affect the trigeminal nerve. So you can get trigeminal neuralgia. Headaches are probably less common as part of an MS syndrome, but if somebody's got a lot of muscle spasm, then they'll get that. It's not necessarily associated just with migraines, but you can certainly have migraines and also be somebody that got MS, and they can occur together.
Brookings, 45-year-old male. I have daily headaches, not one side of my head in the inner eye area. I'm also very sensitive to light. When I take anti-migraine meds, I feel like I'm choking. What are your recommendations?
So that sounds like it's probably a chronic migraine, because a migraine is one-sided and in the area of the eye, the light sensitive, the stuff that he's describing. So he's probably somebody who's changed from an episodic migraine person
to a chronic migraine.
That over time became a daily, chronic daily. And that's somebody who would really need to work with a doctor to see which medications, because I'm not sure what would make him feel like he's choking. There's just so many medications that could be, but probably needs a different choice of medications. Probably needs definitely needs to have something that helps break the headache cycle, and then needs a preventive and needs something to take at the time. So that would be a complicated one. That
so
would be
a perfect example of drugs, if he was without having been treated before, you would pick?
I would probably start in somebody that's depends on the severity of the pain, which I can't tell from this, but if he was in like let's say he's an 8 or 9 out of 10 pain scale patient, I would possibly start him with maybe some IV Depicon and Reglan for 3 days, get the headache down a little bit, start him on a preventive, maybe Topamax, and then start him on something to take at the time, maybe Imitrex, or however that might be what was making him feeling that choking.
I bet you that's
right, that can be maybe Niratriptan, which is sort of a cousin or a sister to it, maybe Rizatriptan, maybe dihydroergotamine. There's lots of choices that I would have in mind for somebody with that story.
All right, go to your headache clinic.
Go to a doctor, right.
Brookings would like to know more about ocular migraines and the cause. And it's just, these are what are the causes of migraines in a sentence?
You know, we think it has to do with overstimulation of the trigeminal nerve, but there's other nerves that are involved, and it involves the occipital cortex, which is why you also get the ocular migraines. There's something called cortical spreading depression, which is not depression like,
sad depression.
Yeah, it's depression of the nervous system. It occurs in the occipital lobe, which is where vision comes from, and so that'll give you those visual symptoms. So there's a lot of theories and there's a lot of change in what we really think is causing migraines, and it's not really fully known.
Right.
This is our theory now, and it's just changed.
10 years from now.
Right, it might change.
Rapid City, 72-year-old male, address, what they understand, MSG, high fructose corn syrup, migraines, acute. The caller gets acute nausea, almost as if it's an allergic reaction.
Well, and it certainly could be an allergic reaction as well, but typically if it's associated with a headache, it's more just a trigger, and it's triggering the headache, which is giving you the nausea. And I haven't really heard the high fructose corn syrup before, but that might just be that person's particular trigger. And so if it does it more than once, that is still your trigger, even though it may not be written up somewhere. It's probably still your trigger, just like the MSG would be a trigger. So you identify your triggers and then you avoid them as best you can. Right.
And if it's constant, then you do a preventative like.
Right, like Topamax or nortriptyline or a beta blocker, lots of choices. Calcium channel blocker, right.
Sufal's Coumadin, does that have effect on headaches or migraines? Coumadin is warfarin
not
with blood
right.
thinner.
It's warfarin. It's not something that I would use for headaches. I can't say I've seen that worsen headaches. It certainly increases your risk of bleed in your brain, and that would cause a headache. But people just on chronic Coumadin for whatever, I don't really see that as causing headaches. Right.
Are there auras associated with eye headaches as with migraines? I guess that we've talked about
Yeah, I think that's probably been answered. I think so too.
Brandon, 74-year-old female, do you know of any treatment of MGJD?
I'm not sure.
Treatment for, I'm just thinking, how about, no, it's not temporal mandibular joint, TMJ.
I'm not sure what they're talking about on that.
Let's take the question of TMJ.
Oh, maybe it could be TMJ. So TMJ is really an abnormality with the joint of the temporomandibular joint, and they'll get some popping, and sometimes it'll stick, and it hurts. And so that causes headaches right, like deep in the ear and in this area here, and go to the dentist.
Yep.
Yeah.
But sometimes, do you think that some of these people with temporal mandibular joint syndrome, chronic pain from that, might also be having migraine?
They could be. It's in the same area.
Yeah.
Right.
It is. Sioux Falls, different between dizzy and headaches. Can blood pressure pills cause dizziness?
Right. Well, so that's something that if somebody started on any of the blood pressure medications for headache prevention, they can start to get lightheaded, and that means that that's probably not the right choice for them, or maybe the dose needs to be decreased.
Reduced.
So that's when I would switch to a different preventive medication.
All right. That and many of the preventives are blood pressure pills.
Right. Right.
So you don't want to go so low as you're having lightheadedness and you're going to fall.
Exactly.
Vermilion, 67-year-old woman, current patient of Dr. Miles. Explain what kind of headaches accompany a concussion, mild or severe, and how does treatment differ for those headaches compared to a regular migraine? So concussion-induced migraine.
So any sort of concussion or traumatic brain injury can worsen somebody's headaches if they were already a migraine person, but it can also bring out headaches in somebody that wasn't a headache person before. And interestingly, it doesn't matter how severe the trauma was. It can be a slight bump to the head and they get terrible headaches. It can be a big car crash and they don't get any headaches. And so it doesn't necessarily have to do with the severity of the injury. Oftentimes those will go away as any post-concussive syndrome in the course of about 2 to 4 weeks, but sometimes they do go on longer than that. And I always treat those just like I would treat any other headache. If it sounds like a tension, I would probably use nortriptyline and maybe some Aleve or maybe a muscle relaxant. If it sounds like it's really brought out migraines, then I would use any of the migraine medications.
Okay. Rapid City, caller gets a headache relief from extra strength Excedrin. Her doctor put her on Plavix. What is the correlation between Plavix and Excedrin?
So Plavix and Excedrin are, I would probably recommend talking to your doctor to see if you should be on them both, because Plavix and aspirin together is going to increase your risk of bleeding anywhere, including in your brain.
So Plavix is an antiplatelet drug that people use after heart disease or if a stroke risk.
Right. And so, you know,
Excedrin has aspirin in it.
Right. And so it certainly could be, with the approval of your doctor, you could take 1 Excedrin a day, but you probably don't want to be taking more than that. So that's one that you should definitely talk to your doctor.
You would suggest a different kind of a headache treatment.
Right. I mean, maybe, let's see, with the age, you know, Tylenol might be an okay choice. You probably don't want to use like Aleve or ibuprofen, because those with Plavix aren't going to be your best choice too either.
Right. So what do you suggest for a plain old headache? Tylenol, probably, in this case.
In this situation, I would probably recommend Tylenol.
But the problem with Tylenol is there's a lot of rebound.
The rebound. So I would say Tylenol, but no more than 3 days a week, if you're going to do it several weeks in a row.
All right.
Right.
Rapid City, 32 years of age woman. How does Excedrin work? Why is caffeine good, and what does it do?
Well, caffeine is interesting because people know that caffeine, if you're starting to get a headache, you can drink some caffeine and the headache goes away. So it can be used as a treatment if you don't use it too much, and if you don't use it every day. But if you're using it every day, then you rebound. So it just becomes a rebound phenomena.
Right.
So what people will find is if they don't use caffeine very much, it's a great treatment. It works. But if you use it every day, it just isn't going to work, and you can rebound from it. But Excedrin really works because it's a combination medication. So it's got Tylenol, aspirin, and caffeine. It's really kind of hitting it from 3 different angles. So that's why it's a good medication as long as it's not overused.
Not more than 3 times a week.
3 days a week.
3 days a week.
Right. Mm-hmm.
And of course, if you don't have headaches and you drink 2 pots of coffee a day, like yours truly, it isn't a problem.
You're just not prone. You could maybe take Tylenol 3 times a day every day and not get a headache either.
Right.
People with headaches are more prone to them. We don't know why.
All right. Sioux Falls, 61-year-old woman. Dr. Miles, what would be her advice for someone who has tried Cephally unit for the prescribed 3 months and it was unsuccessful?
That just might not be the right choice for you, because you can't just turn it up or anything.
Do you use, do you believe in acupuncture?
Yeah, acupuncture is good. And acupuncture has actually good scientific basis to it. And if you're somebody that doesn't want to use a medication, like a lot of times the people that want to use the Cephally are people that don't want to use medication, that might be a good choice. Sometimes if we could put somebody on like a preventive medication, bring that headache down a little bit, then maybe the Cephally will work better. So I wouldn't throw it away, but maybe see if you need an adjunctive therapy with it, yeah.
Wyoming, Sheridan, Wyoming, extreme debilitating migraines. Do you know anything about this condition, Chiari malformation?
So Chiari malformation is something you're born with, and it's basically your brain sits a little bit low, so the cerebellum is just a little bit below the base of the skull. And we know patients that have that are more prone to headaches, and particularly daily headaches, a lot of times headaches that are in the back of the head. I like to treat them like any other headache patient, try to use the medications. Sometimes, particularly with that sinking down further, they need surgery, but surgery is not the perfect option. You're going to have alteration of the muscles back there. They're going to cut your skull. They open up the hole where the spinal cord is coming through, and that opens up a different set of problems. So I prefer to avoid the surgery for the Chiari malformation unless their serial scans are showing that it's sinking down.
Huge answer for her. That was very important. 92-year-old gentleman. I have headaches and stomach at the same time, triggered by light and sound. This started several years ago.
So that even though he's 92 and should have really grown out of them, some people will still have them. So again, in somebody
this is a migraine headache.
That's probably, because with all those symptoms with it, it probably is. And so if you get those once in a while, then using Tylenol and treating early, right when you get the symptoms, will probably shorten it up. If you get it frequently, like let's say 3 times a week or more, you might need a preventive medication, so go to your doctor for that.
How can I tell if my headaches are caused by a combination of prescriptive medicines, in particular sertraline, alprazolam, metoprolol, hydrochlorothiazide, and simvastatin?
Well, none of those look like particularly bad to me, but medications certainly can cause headaches. Like sertraline can, if you look it up, you're going to see it on
the
all
list.
Of them. I mean, if you study
every drug,
right,
every single drug.
If you study 4,000 patients, they have to report if they had a headache. If you look up Tylenol or aspirin, it's going to say it's a side effect. But metoprolol is one we use. Alprazolam is actually helpful for headache. Hydrochlorothiazide doesn't make it worse.
Simvastatin
maybe.
Could.
Right.
That definitely causes
and sertraline,
muscles
maybe.
and bone pain, probably 20-30% of the time.
It's
I give it a 2-week trial off of the medicine, then start it again and see what happens.
But that's a really good point, though, that you should always look at your medication list with your doctor and make sure that's not the cause.
Right. ACE inhibitors can cause all sorts of weird side effects, so those are another group, but that's not on his list. Here's from Yankton, 23, wants to know more about the genetics involved with chronic migraines.
So migraines are certainly hereditary. So if one of your parents has migraines, each child has a 50% chance of getting migraines. If both of your parents have it, each child has a 70%. It's not really, as far as, we don't know that it's linked to a specific gene. There is a particular headache type called hemiplegic migraine that's linked to chromosome 19, but the rest of them we don't know yet. But it is clearly hereditary.
But it runs in family.
Right.
I'm watching the program on headache. It's very good. You might speak about the chronic daily headaches that can be a sequela of traumatic brain injury.
So, as we sort of talked about already, the patients with, like, say, a concussion or any sort of traumatic brain injury can lead to headaches. And those are hard to treat, in my experience. And I really, in these patients, I really listen to the story they tell me as far as what their headache feels like, and then try to direct the medication towards that. If it sounds more migrainous, I'm going to go towards a migraine therapy. If it sounds more tension type, I'm going to go more towards that, or maybe a combination. Sometimes these patients need more of a multifaceted approach, and they need physical therapy and medications and time. Right.
Right. This nurse practitioner student, husband, has had a miserable migraine with aura all his life, or through the years, and now after an ischemic stroke, he doesn't get migraines anymore. It's a blessing, but also a mystery.
You know, I've had a patient like that too. And I don't know exactly why that happens. It changes the brain chemistry somehow. And I don't know how to answer that specifically because I haven't read that specifically, but I have seen that as well. And they're always happy, but it is odd.
Do people who have migraine headaches have a tendency to have a stroke? Is there a higher risk of stroke in that group?
They are at a higher risk, particularly if they have a migraine with aura. And I like not to worry people about that, because if I have a 20-year-old sitting in my office and they have an aura, I will tell them you have a slightly higher risk of stroke, but it's still such an incredibly low risk. So if I take the 20-year-old with migraine with aura and the same exact person without the migraine with aura, the one with the migraine has a higher risk, but they're both so incredibly low.
Right.
So yeah, but there is a higher risk, right?
Yeah. 51-year-old Hovind, South Dakota, headache intensely increases with stress or tiredness. Any tips? And
right, and again, that's a trigger. They're triggers, stress and changing your sleep habits. So if you can't sleep or you don't get in bed soon enough, you can worsen your headache. So it's not just the number of
Regularity is a very
hours.
important
It's not just the number of hours. It's getting to bed at the same time and getting up at the same time. So if you have insomnia, definitely get into your doctor and get that treated. I don't treat sleep disorders, but it's very important to treat that. And sometimes people need to see a sleep specialist. Maybe they have sleep apnea. There's certainly triggers.
Sleep apnea is a real
It's a big
factor.
trigger, right?
Yeah.
So I would probably talk to your primary about the stress and the sleep and see if that needs to be treated.
I'm not a real fan of benzos. I'm afraid if you go to some doctors will prescribe Ambien and benzodiazepam-like drugs for this. But for headaches, where do you fit in your treatment?
I don't use them very often, just because I usually just don't need them. But I would say that they're best to be avoided as well, just because of the other issues that can lead to. But it can help muscular tension, so
Right.
it can work for that.
After surgery, let's see, the patient has sinus infection, no barrier on the right nostril, or no, I'm not sure what barrier. The patient does not have I think probably a septum in the right upper nostril. Can bacteria or viral agents enter the brain?
Well, yeah, I mean, the
Barrier.
viral or viruses and bacteria, if there's any connection, certainly you can get a meningitis. That's a good question for the neurosurgeon or whoever did that. Sinus surgery is whether they need to have something to fix that space.
My guess is that it just opened up the areas into the sinuses, but this is not going to open up the cribriform plate that separates.
If it's not through the dura or the lining of the brain,
You're
it should be
safe.
good. Right.
Right. A food item that Dr. Holm gives people with urinary tract infection in nursing homes, well, that's vitamin C.
Oh.
So I use vitamin C in people with chronic urinary tract infection, and it reduces it in a nursing home scenario 4 times a day. She thinks it was mentioned in a previous episode, wants to know if it's what it is and what it contains. So what about vitamin C, supplements, any supplements helpful for headaches?
Magnesium is, and there's some with butterbur and feverfew. Herbal.
So
Butterbur, feverfew, and magnesium are all proven therapies. And
for preventative.
Right, for preventive, exactly. And so I always tell people just go ahead and get that at your pharmacy. Look on the bottle for the dosage.
Butterbur, feverfew,
right,
and magnesium. But magnesium will loosen your bowels.
There's some people like that.
That's a no.
If you have you on verapamil, you're constipated, so then you add the magnesium, right?
And they're better. And how effective are those agents? I mean, a little.
They're pretty good, actually. And they're maybe not as effective as some of the prescriptive medications, but they're safe, and they're probably cheaper. I guess I haven't priced them, but they may be cheaper.
I think they're probably cheaper. Carpal tunnel, had surgery, still bothering her. What is the recovery time to feel better? That's separate from our issue, but we appreciate it. Any comments about carpal tunnel syndrome? You're a neurologist.
Right. I don't really, we diagnose the carpal tunnel and then we send them on for the surgery, and I don't see them so much afterwards. But with any sort of nerve injury or anything that you've done to the nerve, it can take 18 months for it to heal. Nerves are slow. They're bad healers, and they're slow to heal.
Any take-home message that you would want people to go home with after this is our last?
I think the main thing is if you have chronic daily headaches or headaches that are affecting your life, it's worth going to your doctor, because there are a lot of treatments, and if there's anything we can do to improve your quality of life, it's certainly worth it.
You bet. Well, we so much appreciate you coming and your wonderful knowledge base for us, helping a lot of people. Thank you for joining us on our website. We appreciate all of your questions and the opportunity to answer them. Remember, we're being preempted by the South Dakota High School Football Championships next week, but be sure to join us November 20th on South Dakota Public Broadcasting at our regular time as we discuss the Veterans Administration. Find more of our media online and follow us on social media. And until next time, get a flu shot. Stay healthy out there, people.
Funding for On Call with the Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On-Call Television as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota.
Additional funding is provided by Aberdeen Asthma and Allergy,
Brookings Health System,
Dr. Mark Bubach with Dakota Allergy and Asthma,
Dakota Care,
Dakota Dermatology,
the Orthopedic Institute,
Physicians Care Sanford Clinic Community Service Committee,
and Swiftel Communications.
Closed captioning for On Call with the Prairie Doc is provided by the generous support of
Avera,
Brookings Health System,
and Fishback Financial Corporation.